All right. Professor Tamura worked in Saitama Medical Center. He's a neonatologist, and he was also integral in the liaison between the Japanese Resuscitation Society and ILCO. But he was the principal lead in the development of a pediatric, I guess, would you call the Duck House a rehabilitation facility?
Yeah.
Yeah, and he is here to show us how babies and children with complex medical conditions are looked after in Japan. So without further ado, Dr. Tamura, the show is yours. There are people joining all the time, and they will type questions onto the chat pane or even ask you some questions if that's possible after your talk. So all yours, the floor is yours. Thank you so much.
Thank you. Then I will show you our slide. Just a moment, this one. Can you see?
Yes. Okay, all yours. Thank you.
Oh, sorry. Thank you. Okay. Actually, I was basically a neonatologist. And however, in Japan, the technology-dependent children is increasing. Most of them are graduate from the NICU. And the total number of technology-dependent children at home is over 20,000, especially the number of the technology-dependent children who required mechanical ventilator at home is rapidly increasing. Then I will talk about the background of technology-dependent children in Japan. First is a crisis of perinatal care caused by the development of neonatal care in Japan. As you know, this slide shows the trends of neonatal mortality rate in modern Japan. Now the mortality rate of neonatal mortality rate in Japan is less than 0.6, very, very low. However, on the other side, the number of long-term hospital children in NICU who are not discharged from the neonatal care unit for more than 1 year has been on a steady increase. This blue bar means children admitted to the NICU over 1 year. Red bar is children discharged from the NICU within 1 year, however, with ventilator. As you know, you can see children admitted to the NICU over 1 year is steadily increases. On such situation in 2008, tragic incident, we call it Bokto Hospital incident. A 35-week gestational age of a pregnant woman with intracranial hemorrhage died after 7 perinatal care centers in Tokyo refused to accept her. What was shocking to those involved in perinatal medicine was that this tragedy occurred in Tokyo. Just a moment, okay. Where the perinatal care network was the most developed in Japan. And also the reason many facilities refused to accept the patient was that they had no beds in the NICU. This was shocking for Ministry of Health. So they, in response to this incident, the Ministry of Health, Labor and Welfare conducted a survey of comprehensive perinatal maternal and child care centers nationwide at that time. The most common reason to refusal of admission by comprehensive perinatal care center nationwide was NICU is full. Not only in cases where they refused to admit newborns, but also in cases where they refused to admit mother or pregnant woman. This was very shocking result since the Comprehensive Perinatal Care Center had received state support as the last bastion in the area. This slide shows the causes of difficulties in accepting maternal admission, not neonate, maternal admission at comprehensive perinatal centers. You can see most common reason to refuse maternal admission was NICU full. That means insufficient NICU beds. That's the main cause of the critical situation of perinatal care center in Japan. Why was there a shortage of NICU bed in Japan at that time? Although the number of delivery in Japan was already on the decline, the number of very low birth weight infant and extremely low birth weight infant was on the rise. And also, Japan had a dramatic increase in the life-saving rate of such infants. Such premature infant was not easy discharge from the NICU, and they were long-term hospitalized. Oh, sorry. This slide shows the annual number of births by birth weight less than 1.5 kilogram in Japan. Blue bar means it is a number of extremely low birth weight infant. Body weight is less than 1 kilogram in each year. And red bar means neonate. Birth weight is between 1 kilogram and 1.5 kilogram. Bunkyo hospital accident incident is occurred here. This slide shows a trend of mortality rate of extremely low birth weight neonate in Japan. And previously, the mortality rate is over 80% in Japan. However, it's dramatically decreased. And recent data, when Bokto Hospital incident is occurred, at that time, less than 10%, and that means that 90% of extremely low birth weight infant survived in Japan. This slide shows the average length of hospital stay by week of conception. The more premature infants admitted, the longer NICU beds are occupied. For example, if gestation age is 24 weeks, average stay in NICU is over 250 days. In Japan, the gestation age of 22 and 23 weeks is also we are trying to save. Once such baby admitted to the NICU, they will stay in NICU over 1 year. That means rapid progress in neonatal care caused a rapid increase in life-saving rates. That increase shortage of NICU beds. And shortage of NICU beds is the main cause of a critical situation that threatens the life of the mother as well as the baby. At that time, I was a principal investigator supported by the Ministry of Health and Welfare. This research group launched as a countermeasure for children with long-term hospitalization in NICU. So we requested 200 facilities for severely handicapped children nationwide to accept children admitted to the NICU long term. However, most of the respondents answered it is difficult to accept babies from NICU due to personal and equipment limitation. When I, the principal investigator, was at my wit's end, at that time, Dr. Maeda, he is a pioneer in pediatric home health care in Japan. He proposed, then let's use pediatric home care. This was the beginning of the rapid shift to pediatric home care from children hospitalized in the NICU for a long period. Then the number of children admitted to the NICU over 1 year is started to decline. On the other side, children discharged from the ventilator from the NICU within 1 year is started to increase. Now the NICU beds nationwide has increased much. However, but these children discharged with ventilator from the NICU within 1 year continue to increase. Second part is background of NICU long-term hospital children. What kind of diseases are transitioned from NICU to pediatric home care? This slide shows the underlying diseases of long-term hospitalized children in NICU. 29% of them is background is congenital anomalies. 27% is a very low birth weight infant, and 40% is severe asphyxia. 50% is chromosomal anomalies, and 5% is neuromuscular diseases. And as you know, even if a very low birth weight infant stays in NICU with ventilator over 1 year, once lung matured, they could be weaned from the mechanical ventilator and they will leave the NICU. However, red color children have little chance of spontaneous recovery in NICU. I will talk about each of background children. First is asphyxia. As you know, birth is the most dangerous moment in a lifetime. About 50% of full-term babies need medical support at birth to start breathing. This slide shows the annual trend in early neonatal mortality rate due to asphyxia. The early neonatal mortality rate due to asphyxia is basic, no change in this year. But because I was a task force member of neonatal group in ILCOA, we made neonatal resuscitation guideline 2005, and also we started neonatal resuscitation training program from 2007. Then early neonatal mortality rate due to main to asphyxia is gradually decreasing. However, on the other side, it might increase survivors with brain damage due to asphyxia. And in Japan, the definition of border between abortion and premature delivery has changed from 24 weeks to 22 weeks in 1990. After that, we did nationwide survey research how many baby born in Japan, gestation age of 22 weeks, and how many such baby could survive. On this slide, this red bar is death cases, percentage of death. And this is a survivor discharge from the NICU. Blue bar is a discharge with severely handicapped condition. And yellow bar is they survived with intact survived rate. On 2000, over 80% baby died. Only 15% survived, but only 60% of survival case is an intact survivor. On 2007, survivor death rate is decreased to 60%, and 2010 it decreased. Death rate decreased 40%. On 2014, it's less than 30%. And in our NICU, Saitama Medical School, at last year, the survival rate of gestation age 22 weeks is 90%. However, 40% of survival cases have severe handicap. And they usually stay in NICU for long period. Now they are at home with ventilator like that. About 18 trisory, as you know, that is a very poor prognosis. However, just a moment. This video is presented by Dr. Kajiwara about almost 25 years ago. On this video, this girl is 18 trisomy. She is dancing at her kindergarten. You can see. She's not escaping. That's she's trying what she have to do. You can see. When this video is presented at the annual meeting of neonatologists in Japan almost 25 years ago, at that time the chairman is Professor Hitoshi Nishida, a very famous neonatologist. He started to crying on the chairman's desk because until that time, he recommend once we recognize the baby is 18 trisomy, not try to save the baby because even if they can survive, they have a very hard condition, and not only the baby but also for parents. So don't try to save. That was a recommendation by him. And then, but once he saw this video, what we are doing, maybe we cut such a possibility of the baby of 18 trisomy. After this video is opened on the meeting, many neonatologists in Japan started to try to save the 18 trisomy. So children transition from NICU to home medical care, timing of onset of disability. Before birth is a congenital anomalies, chromosomal anomalies, and at the birth, severe asphyxia or very low birth weight infant. And after birth, neonatal meningitis, cranial hemorrhage. That is the main cause of the disability. So such a baby started to push out from the NICU to home medical care. So this bar means children discharged with ventilator from the NICU within a year continue to increase. Basically, they move to the usual pediatric department once with mechanical ventilator, and 2/3 of them is discharged from pediatric department with mechanical ventilator to home. So this graph shows the annual trend in the number of children requiring home medical care. Left side is pediatric home care children in Japan. This is gradually increasing, and on 2022, total number of pediatric home care children is over 20,000. That is almost a double of 10 years ago. And right side is sorry. Okay. Sorry. Right side is pediatric home care children requiring ventilator. It is now over 5,000, almost 10 times before compared with that of on 10 years ago. Now it's still rapidly increasing. And at this moment, one problem is moving technology-dependent children at home. 1/3 of technology-dependent children at home are movable. This boy is a he has a tracheostomy. He's on mechanical ventilator overnight, but in daytime he's go to school. This school is a very famous Seiko Noda's son. Seiko Noda is a very famous Diet member, National Assembly member. And also, our study shows this is an institution where children with medical care come from. At least 70% of the home care medicines children is from NICU. 60% is from PICU or pediatric department. 40% is unknown. This slide shows the characteristics of pediatric home medical care compared to adult. Total number of home care children is not so many, and they are widely distribution in Japan. Medical conditions are quite different from those of adults, and many of the patients are from NICU and PICU and have a high medical dependency and severity of illness. Many discharged directly from advanced medical facilities, university hospital or children's hospital. And pediatric home healthcare patients are often managed by their primary physician in the hospital with outpatient care management after discharge. Many of home physicians, home nurses, caregivers, and home rehabilitation staff, they are taking care of the adult cases, so they are not skilled in working with severely ill children, especially like children with mechanical ventilator. And sorry. Sorry, it's very noisy. Okay. And there are a lot of individuality in patient, increase body size from 3 kilogram of baby to 80 kilogram of high school boy. For example, many size of tracheostomy tube have to be prepared to take care of pediatric home medical care. And patient growth, development, rehabilitation, and education must be taken care into consideration. But in Japan, there is a care manager for adult cases, but no care manager like adult care for children as insurance. So how high burden of caregiving for family members in Japan, especially for mother, has a very high burden. This slide shows the sleep station or caregivers of ventilated children at home. Once children with mechanical ventilator come to home, total sleep duration of caregiver is less than 5 hours. And also the sleep pattern of caregivers is not continuously. Their sleep is interrupted to intratracheal suction or mechanical alarm. Very, very hard condition. In Japan, the burden tends to be concentrated on the mother. However, for government, there is a big benefit of infant home care medicine. By shifting to home medical care, not only can NICU and PICU bed be utilized, but also the cost of medical care in society as a whole can be reduced to 1/5 or to 1/15. This is because mother will perform most of the work that physician, nurses, rehabilitation staff, and social workers used to do during hospitalization. Part 3 is a school problem. This slide shows the number of children requiring medical care in school in rapidly increasing. In 2006, only 545 students requiring mechanical ventilator. However, on 2018, it increased to 1,502. And so most children in need of ventilator must be accompanied and cared for by their parents in school. So on 2017 to 2018, I did a principal investigator of research on nursing care in educational institutions for children requiring medical care. This intervention study's purpose is we will identify the benefit of eliminating parents' chaperones by involving home care nurses skilled in respiratory care at school for children requiring ventilators. First result is a verification of medical safety. We were able to safely conduct intervention study in 21 cases. In all cases, no major medical or educational problems were observed during the intervention. This result too is a benefit in all cases. For parents, in all cases, the burden on parents was reduced. This is all we had expected before we started this intervention study. However, we could find out unexpected educational benefit for the children and also for surrounding children. First is for educational benefit for children, that children expressed themselves with a fresh sense of joy in studying away from their guardians. By taking classes away from their guardians, the children having to express their wishes to be suctioned through the tracheostomy by the nurses, fostering a sense of independence. And also educational effect for other children, surrounding children. Other children in the same classroom try to interact with a subject child and asked questions about him to the nurse. Then the nurse explained easily why he or she needs a mechanical ventilator and why there is a tracheostomy tube here. Once surrounding children understanding the child condition, it's fostering a sense of camaraderie. Sorry, my poor pronunciation. This girl, she has a tracheostomy. She needs a mechanical ventilator. Now she's start to go to school with visiting nurse. She is expression of independence in the car. Please listen.
楽しみ
She's 独り立ち means independence. She's thinking independence. It's my great joy to go to school. She's thinking like that. And this is a report from one conversation between mothers in one case. Mother who started sending her child with a mechanical ventilator to school, she said to other mother, after sending my kids with medical care to school, I am afraid your child is late for class because my kid is now in the same classroom. Then the mother of a healthy classmate, she answered, what are you talking about? Since your kid is in my son's class, my son has become a real sweetheart. Conclusion. By utilizing home care nurses with sufficient preparation time, we are able to safely provide medical care for children under mechanical ventilatory management without parental accompaniment at the school. This intervention not only reduces the burden on the parents, but also had various educational effects on the subject child and surrounding children. Part 4 is a movement of support for pediatric home health care in Japan. We did research to establish evaluation criteria for the provision of appropriate disability welfare services for technology-dependent children at home. Also in this study, I was a principal investigator. Target is pediatricians in charge at 525 training facilities of the Japanese Pediatric Society for Medical Specialists. Object is to clarify the state of support for pediatric home and issues. This slide shows the number of hospitals that can accept emergency cases of children on ventilator management at home. Left side is a result of survey on 2008. Right side, the result of survey on 2013. In each prefecture, this dark blue means such institute who will accept home medical care children to their emergency department or pediatric department is over 3.6. That is on 2008. Such a prefecture is only a short. However, on 2013, this dark green dark blue prefecture. That means many institute will accept the children who develop severe condition at home is over 3.6. That is increasing, much increasing. Increasingly, more hospitals are willing to accept children who need a ventilator at home in an emergency. And and also we sent a questionnaire on pediatric home medical care support by home care support clinic, basically for adults. On 2009, there are almost 12,000 home care support clinic for adults. At that time, only 1.4 thousand clinics response to our questionnaire. On the survey of 2016, almost over 4,000 clinic response to our questionnaire. And this is actually second question. Have you treated pediatric patient at home? Almost 74% clinic, they have never treated children. And only 31 clinic, they treated more than 10 children. And 2.7% clinic take care more than 5, less than 10 children. And 20% clinic, they are treated less than 5 children. However, compared with the result of on 2009, on 2016, compared to 2009 to the 2016 survey showed a 2 to 3-fold increase in positive response to all questions. So many clinic basically taking care of adult home care, they started to take care of the children. Big tailwind to promote pediatric home healthcare support is started. It's on 2021. The law for supporting technology-dependent children at home has passed through the National Assembly. This act is a law for supporting technology-dependent children at home. This is created to reduce the burden on families raising children with medical care, to ensure the healthy growth of children with medical care, and to prevent their families from leaving workforce. Definition of technology-dependent children at home in this law is a child for whom it is essential to receive constant medical care like ventilator, sputum suctioning, and other medical treatment, etc., in order to lead a daily life and social life. Basic philosophy of this law is supporting the daily life and social life of technology-dependent children at home, and support the technology-dependent children to receive education together with healthy children. Measures that respect the wishes of technology-dependent children and their guardians. and eliminate regional disparities. Specific responsibility of the municipality. Especially, each municipality is responsible for assignment a nurse to ensure the children with medical care can attend the school of their choice without family escort. And also, according to law, social supporting center for technology-dependent children at home have been established in all prefectures. Such support center covering family counseling, and also they provide information and training to support groups for technology-dependent children. Thank you very much for your attention. Thank you.
Thank you very much, Professor Tamura. That was a fascinating talk. We invite questions from the audience. I guess the first thing we think about when we look at your extensive home services is how do you pay for all of that? Who pays for it? Do the parents have to pay any money?
No. Basically, nurse will hired by the school. So local government have to pay the money for the nursing staff. No pay from the parents.
Right. I suppose it's a trade-off between your NICU beds and your home care for the costs, right? Yeah. Maybe if I could invite Dr. Goran to unmute himself. Dr. Goran is our senior neonatal advisor for our state of New South Wales. And I was wondering if you had any thoughts, Robert, on how we could, look at this issue, because we are tending to move towards longer stays and more preterm babies. Is he there? He's there. Robert? No? I might ask him to unmute. Anyway, are there any questions from the floor? No? Okay, so my question is how much education do the parents need to be able to look after a ventilated child at home?
How many?
How much education, how much support do they need? Is it an easy process to transition?
At school or at home?
From the hospital to the home.
From the hospital to the home. Basically, there is a visiting nurse system in Japan, but basically they only can stay the patient to home of 90 minutes, 1.5 hours.
Right.
And other time, parents, especially in Japan, usually in such a situation, father is go to work and the mother is usually stay home and take care of the baby or child.
Do the parents have many relatives that can help? I mean, the burden on the mother would be incredible.
Yeah, incredible.
Yeah. Is there any, are there any parents who have given up and not able to continue their home care?
Yeah. In such a situation, there is some institute. We call it Severe Handicapped Children's Institute. Such institute, but however, as I showed in my slide, many such institute is not so many manpower and also mechanical ventilator. So it is not easy to accept children with ventilator. So usually once one children died, then they can accept another children from home.
So there is a long waiting list.
That's right. That's right.
Okay. What is the average age of children in the home in these institutions?
Oh, it's now increasing the age. Yeah. But I don't know the exact number. But I heard their problem is a transition of children to adult because such institute is started for the children's admission, so they are not ready for accept adult cases. But once child is develop and become adult, it is not easy for them to find out the place for them. There are group home in Japan. That means such a handicapped adults will stay in one house, and some visiting medical staff support, and so parents of them don't need just some visiting time. They will take care, but most of the time parents will stay their own house. But such a group home is not many in Japan.
And just for the audience, just if you can confirm your age of adulthood in Japan is 20?
Adult?
Yes, when a child becomes an adult, it's 20 years old.
Yeah, but no. Actually, in definition of children and adult is 18 years. 18 years.
Mm-hmm.
However, in Japan, every 5 years record of how to say medical insurance will published, not for each year. So we can find out the number of total home medical care is between 0 to 5, 5 to 10, 10 to 15, 15 to 20. So the number I showed on the graph is at that time that our definition is 20 years. But basic definition by Japanese law is 18 years.
Dr. Goran is saying that he has no microphone, but to say that the healthcare responsibility in Australia is with the local health district under a hospital in the home model. And we have a countrywide national disability insurance scheme with responsibility for funding. So I think it's a concept that many of us will need to embrace because we are providing more and more treatment to younger and more complex children who in a few years ago would have had a high mortality rate. So for the last 5 minutes, if there are no more questions, may I ask what is the predominant pathology in the children who are entering your home complex care services now? You showed several pathologies, congenital, heart problems, asphyxia. What is the main problem now facing the children?
Yeah. It's a problem is also the transition from
What's the medical condition? Are they preterm babies? Are they HIE babies?
Or at this moment, we don't know each number, each percentage. But at this moment, our big problem is after 18 years old. The act to support home medical care children is just to support for the children until age 18 years. After 18 years, the support will go away. And so now we are pushing the Japanese government to support such cases who had support until 18 years at home care. If they still stay in home care over 18 years, they should be supported. But at this moment, we are not succeeded.
Not ready yet, yeah.
Yeah.
Anyway, there are no questions, Professor Tamura. I want to thank you again for your time. I know you have to catch a flight. You have to go somewhere now.
Yeah.
So if the recording is okay and you approve, I'll have a look at it and make sure that there's nothing weird in it. It would be great if we could share it with our group for the people who could not make it today.
Yeah, sure. But I'm very sorry. My English is very poor.
Oh, no, it's better than my Japanese. All good.
Thank you.
Thank you very much. And
Thank you.
have a good afternoon. Have a safe flight.
Thank you. Thank you very much.
All
Thank
right.
you.
Bye-bye, everyone.
Bye-bye.
Bye.